Now we proceed with our Dr. Nicholas Barrett again to talk about the evolution of ECMO and the use in the intensive care unit. Please.
Thank you again. I continue to have no conflicts. We're going to change tack a little bit and move away from the heart and onto the other rather important organ within the thorax, the lungs. You're all very familiar with the original definition of ARDS, acute respiratory distress syndrome. Looking at those elements, hypoxemia, low wedge pressure, bilateral infiltrate, and acute onset. However, this patient, on 100% oxygen, PO2 of 4 kilopascals, 30 millimeters of mercury, a PF ratio of 4 kilopascals, tiny tidal volumes, on reasonably well-controlled ventilation, is very different to this patient who is on 50% oxygen with reasonable gases. The patient on the left should be dead by the time you finish your shift, and the patient on the right should not. And yet they were lumped together in all of the original ARDS studies. And that led to a change in the definition, the Berlin definition of ARDS, which kept many of the similar elements. So it kept keep it an early onset within a week or so, bilateral opacities, non-cardiac, but then tried to segregate oxygenation into mild, moderate and severe, with severe being less than 100 millimeters of mercury or less than 13 kilopascals. And we know that overall outcomes have improved over the years. That's potentially in part due to some of our ventilatory strategies, but also potentially in part due to other approaches that we've taken. We know, however, that they remain very high for the sickest patients. If you have mild ARDS, about 1 in 3 patients will be dead before they leave hospital. Moderate, about 40%. Severe, nearly half. 50% mortality, or thereabouts, is consistent, and this is from February this year, so this is not old data. These patients are sick, really sick, just like the cardiogenic shock population, and we need to bear that in mind, and this is just based on your PF ratio that you are this sick. And a strategy of different approaches has been suggested, and we're just going to very rapidly run through these different approaches because ECMO cannot be thought of in isolation. ECMO is a team game, and it is something that we use as part of a lung protective strategy. And without using the rest of the lung protective strategy, you are not going to make your patients any better. We think about low tidal volume, the application of PEEP, neuromuscular blockade, prone positioning, and then finally to ECMO. Standard lung protective ventilation has been with us for not quite 20 years, but not far off it. Bringing the volumes down to 6 mils per kilo, bringing the pressures down below 30. And I guarantee that in both your intensive care and my intensive care today, we're not doing it well. Guaranteed. You know how I know? Because we have tried to measure the height of patients. And in measuring the height of patients to give their predicted body weight, we get a difference of up to 15 centimetres, depending on which of the nurses does it. And that's because in patients lying down flat, it's really hard to measure an accurate height. And 15 centimetres is quite a lot of volume. So nonetheless, we need to try to get a lung protective strategy. We need to use PEEP. PEEP does a number of things for us. It improves our oxygenation, and you can see here on the left with the application of sustained PEEP, what we're doing is the alveoli are opening up nicely and then we're ventilating on top of them. With the one on the right, you can see there that the alveoli are opening and shutting. You can see the inflammation occurring within those alveoli. You can feel the ventilator-induced lung injury which is happening. So PEEP is not just there for the improvement of oxygenation, but it's there for the improvement in ventilator-induced lung injury and for the improvement in inflammation at the alveolar level. We know that as PEEP goes up in our sickest cohort, it's associated with improved survival. We know that if we run patients at that higher level of PEEP, it's better. Setting PEEP can be difficult. Many people do a 40 by 40 centimetres of water for 40-second recruitment manoeuvre. And this is what a recruitment manoeuvre does. It opens up the alveoli. And you can see the way that you've gone from a completely collapsed lung, clearly not human, through to, by the time you get to the 40-second mark, progressive opening of alveoli. The problem with this particular manoeuvre is that although you can temporarily open up the lungs doing this or using, say, for example, a bagging manoeuvre, you're not going to be able to set the PEEP. And what you really want to do is to try to titrate the PEEP to the highest level that the patient needs. You can do that through a recruitment manoeuvre. And this is the recruitment manoeuvre that we would routinely use. So you go continue, same driving pressure, rise up on the PEEP, then come back down. And because of the hysteresis within the lung, you'll find that you open up the lung at a higher pressure than the lung closes. So if you don't open till 18, but you close at 12, you know that you can set it somewhere around the 15 mark to take benefit of that relative pressure relationship. We know that neuromuscular blockade is very important and has improved survival. We know that prone positioning is important. We know that nitric and steroids both improve the numbers but don't necessarily improve outcome to an unselected population. And things such as inhaled and intravenous beta agonists cause active harm, as does oscillation. Either no benefit or harm. What's really interesting in the oscillation story is that if you look between the two studies here, on the left you've got the American study, on the right you've got the UK study. On the left they managed to get 7 mils per kilo in the control arm, and on the right, the Oscar study, they had 8 mils per kilo. And there is a suggestion, albeit it's not statistically significant, but a suggestion that as you come down from 15 mils per kilo down towards 6 mils per kilo, at around the 10 to 12 mil per kilo mark, you're starting to see an equivalence of oscillation with conventional ventilation. It may be that oscillation is better than harmful strategies, but not as good as protective strategies. There is also the question that we don't really know what optimal protective ventilation is. And this was a retrospective analysis of the ARDSNet papers which looked at the inflection point. You can see there's a clear change in the mortality after 25 centimetres of water. And it may be that we actually need to bring the pressures down. It may be that we also need to bring down the driving pressures. And this was Amato's work from late last year, looking at driving pressure as it relates to outcome and mortality. Now, of course, it's an observational study. We can't imply causation. It may be that just the stiffer the lungs, the worse the disease, the worse the outcome, rather than the other way around. Nonetheless, it's an interesting signal. And it does make us wonder exactly what's going on in the lungs. So what is going on in the lungs? Well, on the left we have mild disease. We have patients that we see every day. They're on 30-40% oxygen. And you can see the missing bits of lung at the back are where the consolidation is. But the front portion of the lung is nicely aerated. Now, these patients will have 3.5 litres out of their, assuming they're a 70-kilo individual, 3.5 litres of aeratable lung in which to ventilate. So we're using only 11% of their lung volume is being used in our 420 mil tidal volume. By the time we get to this patient in the middle, where you can see you've got far more extensive consolidation, far less lung is available for gas exchange, this moderate problem, you've got 1.5 litres of volume. And we're up to 26% of the available lung capacity because of the heterogeneity of the disease. By the time you get up to the end that we're looking at ECMO for, you've got a tiny little bit of lung there, 280 mils. You're trying to push 420 mils into 280 mils. You can see immediately why we have to have different strategies as patients get sicker, and why lung protective ventilation is not necessarily protective for all patients. The problem is, though, that as we reduce tidal volume down to 4 mils, 3 mils, 2 mils, 1 mil per kilo, we get a steady rise in CO2, which results in acute pulmonary hypertension, right ventricular dilatation, and overall cardiac failure due to the left-right ventricular interdependence. So it's a problem. So this is the population when we need to think about vena-venous ECMO, where we take from the venous side and return to the venous side purely to alter the oxygenation and CO2 clearance of the patient. If we look at the limited evidence, because it is only limited evidence in support of ECMO, what can we say? Well, in the swine flu pandemic, swine flu did the honourable thing and went through the southern hemisphere first, where I came from, down in Australia. Australia, because of virtue of its geography, has a regionalised healthcare system where you have large centres in capital cities and then a very distributed network, because you have to. That's the way the population sits. People are used to travelling 1,000 kilometres in order to access healthcare at specialist centres. That's normal. And as part of that, they used ECMO for the provision of severe respiratory failure, so that A, you could transport people, and B, it was in a specialised environment. What they found was that using that in swine flu, they had an 80% survival. Non-randomised, purely down to clinicians choosing who to put on, but an 80% survival, which had never been seen before in respiratory failure. We then moved on to the CESAR study, which came out at around the same time, which looked at the provision of ECMO in a specialist centre versus the provision of conventional care. Now, it's important to reflect that the CESAR study was not ECMO versus no ECMO. It was specialist centre with access to ECMO versus non-specialist centre without access to ECMO. And some 80% of patients achieved ECMO in the ECMO limb. They found a significant mortality advantage to going to a specialist centre which provided ECMO. And then in the subsequent swine flu pandemic as it hit the UK, those patients, case matched, so propensity matched, observational series, 80% survival if you were 25 with swine flu and no comorbidities and went to an ECMO centre, 50% survival if you didn't. ECMO is not necessarily about providing an individual patient who is guaranteed to die with an advantage. It's looking at improving the overall survival. You can't guarantee that the patient you give statins to, it will prevent the myocardial infarction. But you do know that if you give statins to a large number of people, that you will reduce the overall burden of disease. And the same is true with ECMO. You need to look after the patient's lungs, make sure they are sick enough, but what you really want to do is you're not looking at it as salvage therapy in the peri-arrest situation. You're looking to apply it in patients a cohort of patients who will benefit. We've seen a massive rise in the number of ECMO cases which have been done in the world since really swine flu came around, particularly with respiratory ECMO. Who do we need to look at? This is one example. This is a patient selection using the PRESERVE score, and what they found was that patients who were younger, patients who were plumper, patients who were less sick all did a bit better, and that makes sense in general for critical care. It's consistent with the rest of critical care literature. We know that cachexia is bad, age is bad, etc. What's really interesting about the PRESERVE score is look at the bottom half there. Mechanical ventilation for a long duration, not being prone, not having the right PEEP, having too high a pressure, too high a volume. They were the things associated with worse outcome. They are all things that we can correct in our intensive care today. And they found a massive difference between the two groups. So if you take your 21-year-old with swine flu and you ventilate them well, you're looking at a 95% survival, which is what we have. If you ventilate them badly before ECMO, they've got a 50% survival. In the UK, we've developed a system on the back of the CESAR study looking at a specialist model of care where we provide care to about 15 million people. We have strict criteria, early, sick enough. We use the Murray score, and we don't offer it to everybody. If you are dying of something else, you don't get access to ECMO. So if you've got a malignancy, etc., we don't go there. What sort of patients do we have? Many of them have CTs like this, complete hepatization of the lungs by the time we get them onto ECMO. And this is a common thing. But we also offer it to trauma patients, and they can do just as well. This is not artifact, that is a post through the chest, managing to miss every vital organ on the way through remarkably. Pulmonary hemorrhage, often considered a a contraindication to ECMO, do very, very well, albeit you need to run them without heparin for a while. The same as intracranial hemorrhage. And these are real CTs in real patients we've had, and they've all been neurologically intact afterwards. 1 in 8 patients on ECMO will have an intracranial hemorrhage at the beginning. Run them without heparin. ECMO gives you advantages in terms of a distributed healthcare system. It allows you to transport the patients. You can transport them by air, by road, by sea, however you wish to do so. We have a physician model, so a pure intensivist model. Our surgeons are delighted to assist, but delighted to stay home and be in bed as well. And that's what they spend most of their time doing at night, whereas we run around the countryside putting people onto ECMO. So we use ultrasound. We use fluoroscopy in order to target. And then, similar to the cardiac program, we're looking at lung rest, identification of the problem, and adequate gas exchange. We have a fixed diagnostic pathway where every patient gets access to CT, everyone gets echo. In my view, there's only one indication for echo, and that's that you've got a heart. If you haven't got a heart, you don't need an echo. If you do, you need an echo. Everyone gets an HIV test. 2% in the UK population have HIV. We do a recruitment scan, looking at differential pressures. The patient at the top has significant non-recruitable lungs. The patient at the bottom recruits very nicely. It may or may not help you in terms of the immediate ventilator management, going up to 40 centimetres of water, but it does help you for some of the diagnostics and looking at the lung parenchyma. It can also help to better target your proning. Once you're on ECMO, you need to think about lung protective ventilation. I'm on this ventilator, that's in litres, so we're talking about a 40 ml tidal volume. Tiny volumes. Step back, rest the lungs. You can also get people up and walking around. So you don't need lungs to exercise. They're not important things once you're on ECMO. So this patient's standing up. This young lady is playing on the Wii. She's just out of shot is her lunch. We can also go a bit further afield. Go and have a little tour of the river, sit by the Thames, look at the Houses of Parliament, watch the world go by. Very useful when you're awake in an intensive care, because they're very boring places, I'm afraid. And you can get up and walk around. Why shouldn't you? Lungs are unnecessary to get up and walk around. So get up, get your patients up. These patients are femorally cannulated. They can be walked around. We tend to put the cannula in a little bit further down the thigh than the groin crease. And you can ride a bike. In this case, this young lady is on the hand cycle rather than the foot cycle, but you can happily ride a bike on ECMO. Why does having a national service work? What is important? It is not just me. Okay, I have a massive team. I have doctors, I have nurses, I have physios, I have perfusionists, I have dietitians, I have speech and language people, but I also have a population of 15 million people. And I'm the primary ECMO centre for those people. As a result, we get volume. Volume we know is important. Volume is really important. Nobody goes to a mitral valve surgeon who does one mitral valve a year. You'd laugh at the surgeon. If they said, I do one a year, I'll happily do yours. You'd say, don't be silly. We know volume is associated. We know that it's associated in cardiology. The more caths you do, the better you get. We know that it's true in ARDS in general, and we also know that it's true in ECMO. And this is data from late last year, looking at the ELSO database with survival as it relates to outcome. So size is important. We do about 120 cases. This was last year's data. Steady rise over the last 5 years in cases. And this is our survival, going from ECMO survival on the left, which consistently is around the 75 to 80% mark, through to hospital survival, ICU survival, in the middle. There's always a small drop-off, through at the far end to 6-month survival. So these are patients who are back home, not necessarily entirely without problems, particularly psychological problems we see after ECMO. It's a younger quotient patient cohort. But they can do extremely well, but ECMO is only a small part of the package of care with severe respiratory failure. Thank you very much, and please join us in EuroELSO next year.